Dustin Moffitt, who is a native Kansan. Dustin is from Whitewater, Kansas. He did his undergraduate here at Wichita State, but he's a naturopathic physician. He went to the National University of Natural Medicine in Portland, Oregon. And so the Riordan Clinic, we feel extremely blessed to have him as part of our staff because he may be the foremost expert in the Midwest as far as this new regenerative injection technique goes. And so today I'm just going to be really informal with him, and by all means, any of you, if you have a question, Dr. Ann's got a microphone, and raise your hand. But Dustin, are you there?
I am here.
Dr. Hello. Dustin Moffitt, so welcome.
Welcome to the talk. I don't know if anybody can see me. I can't see you, so
yeah, you're kind of a little postage stamp up in the right-hand corner of the letter here. So, but right. You look good. So maybe what you could do is tell us just a little bit more about your background and what drew you into this particular field, and also a little bit about your training in natural medicine.
All right. So I was originally gone allopath, which is conventional medical school. I ended up choosing to go naturopathic just because I felt like there were more options, and the conventional medicine just wasn't fitting the picture that I had seen for helping with patients' health. Once I was in naturopathic medical school, I kind of got more intrigued about the regenerative injections. I was shadowing a lot of doctors that were doing it. I started doing preceptorships with them, and then I've even done postdoctoral training for all the injections. And I've been using it clinically in my own practice for over 2 years now, and I've seen a lot of great results with it, and a lot of people have really got great pain relief from it and are able to return to a lot of their daily activities. I myself have benefited from it quite a bit. I've been a chronic pain patient for about 16 years now, and it has helped me relieve a lot of my pain personally more than anything has ever done in the past.
Well, just to put a little personal note in this, Dr. Moffitt has helped me a lot with some pain. But as a doctor, I was surprised in my first year out in family medicine, I was given the job of reviewing chest x-rays. And when you look at a chest x-ray, you can see through to the vertebrae. And I was amazed that just about every chest x-ray that I was looking at, I could see the little bone spurs and the degeneration of the spine. And then, of course, you probably have friends or know people who have had knee replacements and hip replacements and various joint replacements. And while the science is wonderful, it's still a major undertaking. There are risks associated with it, and so I'm hoping that Dr. Moffitt can kind of convey to us what is so revolutionary about regenerative injections. Obviously, it's the opposite of degenerative. So, what is a regenerative injection, Dustin?
That's a great question. So a regenerative injection is really meant to regenerate that tissue. So we're not really doing anything excess than just causing some basic inflammation in the area to restart something called the wound healing cascade. I'll actually pull up a picture of that right now. So a wound healing cascade is something that every single injury in the body has to go through. As you guys can see here, we've got a bleeding in the area to bring in blood flow, then that inflames the area. So inflammation, that's the biggest thing that I have to relay to a lot of patients. That's inflammation is not a bad thing. Yeah, it's not very fun to go through, but that inflammation, as you can see, is a part of this entire healing cascade. So without that inflammation, we don't get to go into the next stages. So if you stop that inflammation, you literally stop the body from healing the rest of the way. And what these injections do is it makes a very controlled injury in the area in a way that we're trying to help the body become more aware that, hey, there's a chronic injury here. If we're speaking about a chronic injury, there's a chronic injury here that did not heal properly in the first time. And what I do is I go in and create inflammation, and that's going to bring in a lot of your body's own natural things to, sorry, I'm trying to get rid of some of those drawings, to bring in the rest of this healing. And so down here, you'll notice that there are fancy little pictures. Really, that's just kind of a scientific figure that I like to show. It's showing what each of those steps of that process are bringing in. And I'm going to point to a couple different ones. So really, this VEGF, what that just means is it's going to bring in new blood flow to the area. It's also going to bring in new nerve fibers. And then if we get into this later aspect, we're going to get new collagen development with that MMP, metallomatrix proteases. So what that does is it really helps rebuild. Now, granted, this looks like a cut wound, but your bones heal that go through the same process, your ligaments and tendons. And with the regenerative injections, we're really treating those ligaments and tendons because they're not really the weakest point. The weakest point in the body when it comes to that lever action with the bones and the muscles is something called an enthesis point. The enthesis point is where those bones or the tendons and ligaments actually adhere to bone. So they're kind of going in there, and if they slightly separate, that can be a very large pain generator. Our tendons and ligaments actually have a lot of nerves in them that help us detect stretch on a muscle. If you guys have ever been to a massage therapist or a chiropractor, they'll say that you have very tense muscles around any area of injury. That's because when those tendons and ligaments aren't there to hold it together, the muscles have to kind of take that up. So inevitably at the end of the day, what the regenerative injections are doing is just basically hitting a restart button on your body's own basic ability that it has built in to heal your wounds. It's just sometimes maybe something just didn't go through the proper mechanism, or it didn't get time to fully heal. Or another one that I see chronically, we're seeing a lot of NSAID use. So not Tylenol, aspirin, ibuprofen, Aleve, all those guys are non-steroidal anti-inflammatory drugs. And what we just went through is the need of that inflammation to actually heal the body. So sometimes putting up with just a little bit of pain will actually help you out better in the long run to prevent some of these chronic injuries.
So just to kind of reiterate what I consider as a basic point of the presentation is that I think from a conventional perspective, inflammation is the enemy. And much of what's done in the interest of trying to control inflammation is to use steroids or non-steroidal anti-inflammatory medicines, all kinds of things to try to stop inflammation. But what you're saying is that in this regenerative injection technique, you're actually beginning to modulate the inflammatory process in such a way that it is able to achieve what the body wants to achieve, which is healing. You're not trying to interfere with the healing process. You're trying to regulate it in a way that it achieves its purpose, its end.
That's very much so. I'm not doing anything new here. I'm really just amplifying what your body's natural ability to do.
Can you give us a little bit of the history of this? Because we've been doing regenerative injections here at the Riordan Clinic for only about 3 years. And so how far back does this go, Dustin, and when did it kind of get started, and give a little background to it?
All right, so they've actually found that some of these regenerative techniques have been dated all the way back to the 1830s, but it's not really predominantly known until the early 1900s, and that was when a couple doctors kind of took off on making this their own medicine. And the two biggest ones that come to mind are a Dr. Hackett and a Dr. Himwall. They've really perfected a lot of those injection techniques and have led the industry in a lot of the research that's out there to kind of back this up. And then there's also Dr. Hauser. He's really good at leading a lot of the published researches, but it's been dated back way long before even now. People think of it as a new therapy, but it's really not. It just has been kind of forgotten about because I think it's the fact that, yeah, there will be an occasional flare-up, but as you can see, we need that inflammation to get through this. Cortisone shots are the most predominant thing that are used at a lot of medical offices, especially orthopedic offices. And there's nothing wrong with that therapy. It does stop pain. However, I do see a lot of those patients come into me where I'm actually having to kind of go in and clean up the mess that those guys, the injections have left behind. And it's just because it never allows it to fully heal entirely, because we're missing out on that inflammatory process that lets us heal. Just to reiterate, this is not a new therapy. It's nothing new that we're doing here. There are always new techniques that are coming out. There's new adjuvants or something that actually is used to irritate it. So I just use the old standard irritation, which is it's a dextrose prolotherapy. And all dextrose is a sugar water solution. But what that sugar water solution does is it acts on a couple different mechanisms. Let's see if I can pull up the picture and kind of walk through it. So the dextrose, basically what it does is it goes in and it fuels more of this inflammation in this area by drying up the extracellular tissue around it. And then what that does is it pulls in a lot of these neutrophils and macrophages into the area, which then also can work later on down the line to start affecting nerve fibers. I don't know if you guys can see this very well, but basically the scar tissue, as you notice, there's a lot of kinks and twists in here and things. When I see a chronic injury, now granted, like I said, this is a new injury here, but when I see a chronic injury, really what that cartilage is looking like, it's kind of a twisted, combobulated mesh like this, sort of as if you're kinking a water hose. This is a tendon or ligament. So a tendon or ligament should really be smooth and move like this. All the strands should kind of go together instead of looking like that twisted up knot. But when we actually use that dextrose prolotherapy, that's the lowest intervention that I do. The dextrose prolotherapy I tend to use in most of my cases, but when I inject that, what I'm doing is I'm basically liquid dissecting or spreading out some of those fibers so that hopefully they're more like this, so that when that healing cascade goes through, they can start lining up more properly so that we get something that the water hose is not kinked anymore. So those nerve fibers and the blood flow can perfuse through there better. So for instance, when I'm injecting a scar tissue, I do a lot of scar injections for people that have had those surgeries in the past. And then if you guys have ever seen really dense scar tissue where if you palpate over it or feel it, it's very crunchy, and that skin tends to be white around it. When I actually do these injections, we'll see that scar tissue will slowly start to turn towards normal looking tissue. So it'll get that pink back, and people will start noticing that they feel itchy over that scar. And that's actually those nerve fibers coming back into that area. So a lot of times people will have no feeling over where they've had that surgery before. This can reestablish that. And then since I did mention the dextrose prolotherapy, I'll kind of pull in and show the levels of intervention that we do with these regenerative injections. Riordan has been doing the prolozone injections for quite some time. I didn't actually use the ozone before coming to Riordan, but have seen amazing results with it. I was already getting good results with just my standard old dextrose prolotherapy, but I get about 10 to 15% better results by pairing that with the ozone. And Dr. Ron could probably go into a lot more detail of the ozone's benefits than I could, but the ozone therapy is kind of a good starting grounds. The dextrose prolotherapy is more of an irritant and kind of is the next level. A lot of people are now hearing of stem cell therapy. We're not doing that here at this clinic, but we do platelet-rich plasma therapy. And platelet-rich plasma therapy is just one step under the stem cells. And they basically all mount the exact same response. It's just as you go up that tier, each response gets a little bit stronger. To really get through this whole healing zone a little bit quicker. So if I see a lot of athletes that especially need to get back on the field, or in our case here, we treat a lot of farmers, and so now it's becoming busy time for farmers. If I get them in here with a quick injury, it's probably going to be platelet-rich plasma to really get them through that healing as quick as we can so that they can get back on the farm and get their harvest going.
Just to kind of reiterate some of the stuff that you're talking about, when we first started doing prolozone therapy, it was a little bit, coming from the allopathic conventional medicine perspective, where the goal was to stop the pain and to use anti-inflammatory medicines to do that. And also the idea that when you have any kind of pain, usually that's a signal from a site of injury within the body. So what was a little hard for me to understand is that prolozone and prolotherapy are a kind of controlled re-injury that the doctor, the therapist, is putting into the area that has not healed properly and that has become a chronic wound, and that what you're really trying to do is straighten out the healing process. And one of the benefits of what is injected, like dextrose or ozone, is these don't stick around for very long. They're mostly just acting as somewhat of a stimulant to the healing process, and then it's up to the doctor to kind of control it and to repeat it at the proper intervals so that the healing can then come about in a way that results in true healing, to where you don't have the chronic pain, because pain is a signal that something is still not right. Now, does that fit your model pretty well, Dr. Moffitt?
Yeah, I would agree. The pain is a signaling system, but it's not a bad signaling system. Yes, there can be such thing as too much pain, and controlling that can definitely be a big factor. Like I'll actually bring up the cortisone shots. So the only time you'll really ever see me administer a cortisone shot is, let's say, I'll use my elbow just because it's a joint I can show. So if this guy were really big, hot, and inflamed, and it's going to end up causing too much damage to where maybe it's going to lead to a reactive arthritis or something, that's where I would throw cortisone into there to really slap that inflammation down as quick as possible so that it quits degrading that joint and bone too quickly. That would be too high of a response. But if you come in and, you've got an achy elbow because you bunked it, or maybe you've got tendonitis on that lateral elbow, which is pretty common to see, that's not a bad thing. That's your body trying to say, hey, our flag system is going off. We need to really pay attention to this. This pain is not only there to let you know to slow down and maybe protect that joint, especially with those lateral tendinitises, but that's also your body internally reflecting back on initiating these guys. So those pain signals actually bring in those macrophages and neutrophils to go through that work. If you've ever gotten a bruise or have bled, those platelets, so most people think of it just as forming that clot, but those platelets actually bring in the biggest growth factors. If you see this PDGF, so platelet-derived growth factor, and growth factor means growing. So it's going to be stimulating more growth within your body to bring that in, which is why the platelet-rich plasma. So what that is it's your own blood, where we spin that down and process it to get platelets at a higher concentration. So we shoot for about anywhere from 6 to 9 million platelet count, where your body normally is nowhere near that. So those platelets all can go into that area, but dextrose alone and just the poke from the needle actually causes your body to bleed a little bit into that area, starting this factor as well.
So we've been talking about the whole theory of regenerative injections. Let's kind of walk through a real case scenario. And I had a gentleman in here a couple days ago, and for the last 5 years, he's had knee pain, the left one worse than the right. He had previously had surgery on the left knee, and he had the meniscus, which is the cartilage, the medial meniscus on the middle part of the knee, had been removed several years ago. So he has a lot of pain, and he's been doing some heavy lifting, and that has really exacerbated the pain. So Dr. Moffitt, kind of pretend like the audience is that guy, and they've got a knee problem. what would you be telling them about? And they're here to talk to you about getting some kind of an injection. They've heard that there's something that's going to help their knee pain. So what exactly would you be telling them you'd be doing and why you would be doing it and how it's going to help?
All right. Can everybody actually see this picture of the knee I pulled up?
Yeah.
Okay. So I'm going to use a little pointer, I think. Here we go. So it sounds like his knee is worse when he's under load bearing. Right. So I'll just kind of use him as the example when I'm describing through this. So when we have load bearing, we're looking at the knee here, and in this case, looking from the front, this would be a right knee. So pain generators, when it's under a load, we have to be stabilized first. So I get a lot of people in here that not only have instability, but they've also got that pain. As you see here, the cruciate ligaments, these are called the ACL and PCL ligaments. Then on this side, we've got the medial collateral ligament and the lateral collateral ligament. Actually, there are two of them on this side. But what those guys do is they stabilize this knee so that it can't move forward or backward or bend from side to side too much. We just like that knee to be a hinge. So that hinge is just going to open and close. We don't want it hinging and slipping as we go. So to keep it from slipping, now this is a poor representation of what the knee actually looks like. These are the meniscus here in between the bones. The meniscus actually looks like two horseshoes that kind of come together, and they form a ring that goes around where we have annular ligaments around the outside that actually stabilize and concrete that meniscus in together. They're a very dense collagen fiber or cartilage, where on the inside we actually have a pulpous material that's more soft and more giving to allow with that. We also have the articulating cartilage on the bone surface here. See this white form on the bone? So that is actually supposed to be a very smooth surface. So this gentleman with weight-bearing activity most likely has some meniscal instability, whether there is a tear in the annular ligaments that actually, when he goes and weight bears, that tear actually will, so if I'm making a cup, as he goes and puts weight on that, it's going to kind of pop and click. So that's very indicative of a meniscal tear. Now, whether it's a complete tear or just microscopic tears that are little pinpoint spicules that actually cause that to catch, or whether if it completely pushes out and loses all that stabilization and pivot point. So that can be a cause of the degenerator. Also, when I see any kind of a meniscal tear issue, especially if it's a chronic issue, more than likely these medial collateral and lateral collateral ligaments that stabilize that knee on the side, they basically hug that and keep it together. If those guys are loose, what that's going to do is allow slopping in that knee and keep worsening, grinding down that meniscus. It's basically like trying to take a hinge, and yet that hinge keeps popping apart each time you go to close and open that door. So what we do is I treat a lot of these ligaments here with the dextrose prolotherapy, and most of it is at these enthesis points here where they join onto the bone. So what I'm trying to do is basically re-glue that ligament down. Occasionally you will see microscopic tears in the middle areas here, and then also I can often feel with my hands the bursa is inflamed in this area. I've also been noticing a huge trend of patella chondromalacia, which is basically a painful signaling that comes from the kneecap here. And I've been noticing there's a lot of arthritis that's forming underneath this, as well as adhesions, which basically just means a fancy word for scar tissue that's forming all in here. So that patella, as you can see, are quadriceps muscles. Most people know those are the muscles on the top of the leg there. Those actually all link to these tendons here. And then the patella helps it glide back and forth smoothly over this big crevice here that we see. And then it attaches to another ligament that comes down here. So if that guy is tracking improperly, maybe it shifts to this side and gets caught on this bone and then pops and clicks, or shifts to this side, catches and pops and clicks. all those can really come together to be that pain generator when it's under load. That being said, we're also seeing a huge likelihood of osteoarthritis coming with people that are suffering from something called sitting disease. So sitting too much can actually lead to this being torn apart. I'm actually noticing that a lot of my most active patients tend to have the most stable joints. I don't have to do as much cleanup on stabilizing these side streets here, because when you use your body all the time, what are you doing? You're generating more inflammation. And then that inflammation is causing it to heal itself. So the more you use it, the more it's going to predominantly stay more stable. It's not always that way, but sorry, I forget which one. Here we go. But it's a way to kind of keep regenerating that movement in there. Does that kind of answer some spots?
Just to recap what you've just said, and it kind of helps me think about the different types of injections that you're using. You're using the dextrose injections to strengthen and stabilize the ligaments in order to get the mechanism of the knee working more properly, because the mechanism being out of whack can cause some of the more rapid degeneration. So if you just try to fix the cartilage and fix the interior of the knee without stabilizing the overall structures around the knee, you're not really solving the problem. So the dextrose injections do that, and then the ozone injections into the knee. Talk a little bit about that, because I think a lot of people may not know that much about ozone and how ozone might be of benefit to the interior of the knee.
Okay. So the way I like to describe ozone to a lot of patients, just to kind of keep it on an easy to understand method here, everybody knows hydrogen peroxide, right? So hydrogen peroxide, if you were to pour that on an open wound, what does it do? It bubbles and boils and kind of disrupts that cellular membrane to clean out that joint. That's kind of what ozone is doing internally. So ozone is actually bringing more oxygen into that area, and actually knees are the best example to show that. So oftentimes when I'll inject a knee after I've done all the other injections, I'll inject the knee with the ozone, and the ozone actually will vasodilate or open up the vasculature system, because our bloodstream just likes to absorb it so rapidly. So what that does is it causes a huge flush of blood flow to the area, which blood flow, as we remember, is actually what brings in a lot of those nutrients to do the healing. So it's opening up the blood flow to the area. Oftentimes it'll actually make a little bit more bleeding happen within there, because we've already gone in and done a little bit of controlled inflammation and controlled injuries to kind of reiterate that. But it's also going to bubble at that. So I'm going to use osteoarthritis. So that basically just means a little bit of arthritis in the larger bones. So osteoarthritis will often see a sandpaper-like formation on what this area of the bone should be. It should be a very smooth coating. So osteoarthritis actually causes this to begin to look like sandpaper and feel like sandpaper. And if you've ever tried to slide sandpaper over sandpaper, it just doesn't slide very well. We really want that to be like a smooth vinyl surface where you're trying to just make those things go across each other. Or if you put oil between your fingers, you want it to glide like that. So that ozone is actually going to help irritate this area and bubble away some of those. And then also it alone can generate some of these growth factors by itself too. So ozone, it's just another benefit on top of the treatment that we're already doing.
So here's our patient sitting on the table, and he or she is wondering, is this going to hurt? What kind of, do you use a big needle? Do you use any numbing medicine? Could you just go through the practical steps of what you do when you inject a knee?
Okay. So there is always going to be discomfort, especially while on the table, that nobody likes getting poked. I mean, you're getting injected. There's going to be some discomfort within there. I do poke a little bit more, but it's because I tend to be as comprehensive as possible. So let me pull up another picture here. We'll use a sacrum. So this is your back. We're looking at this person's back right here. This is called the lumbar spine here, so low back, and then sacroiliac joints here. And this is a great example that's made by Caring Medical Clinic. So it's actually ligaments. These are the sacroiliac ligaments that stabilize the hip bone to the sacrum. So I'll use this as the example just because you can see the redness shows the irritated. So this is an example of sciatic nerve pain, but there are three causes of sciatic nerve pain, in my opinion. Nerve root irritation, which starts up here in the lumbar spine. Then these sacroiliac joints. We've also got a piriformis muscle that goes right over here. It's not actually depicted in here. But say if I were to inject this area, I'm poking all along here because you can see all these different ligaments, and that injectant, so the dextrose prolotherapy, for example, the liquid does not travel very far. It travels 1 to 3 millimeters, which is about as wide as my little mouse head is there. So literally, we have to go along and poke in here. The key is to go to a practitioner that knows what they're doing. They know where to go to hit these. And as they become more proficient with this, it's going to be a lot easier to do the needling, which decreases that discomfort that comes along with it. So inevitably, the more stable my injections are, the less likely it is going to be irritated. If a person is very scared of getting these injections, there are things that we can do to make it more comfortable. For example, we can apply a topical lidocaine cream and let that sit, but that actually makes the procedure a little bit longer. But that can numb the pain receptors, because honestly, most of the time the discomfort that people feel are when it's first passing through the upper layer of the skin. Once it's down in this area, most people tolerate the injections actually quite well. Okay, so.
But do you also use Bupivacaine injections like in knees and different places as well? So there is a pre-numbing injection as well.
All of the injections are, so we'll just talk about what's in a dextrose prolotherapy. So Bupivacaine is a local anesthetic, which will inhibit a lot of these nerve fibers so that it numbs the area. Yeah, you'll feel a little bit of stretching, but pain-wise, once that kicks in, that pain deep down kind of disseminates. However, like I said, most of the pain is actually felt on the skin surface. The other ingredients are cobalamin, which is a vitamin, and then we have the 50% dextrose there that we throw in there. And so all of those kind of come together to make the perfect dextrose prolotherapy. You'll see other providers, they may add in hyaluronic acid or chicken cartilage or something like that. I found that I don't need those fancy injectants. I'm able to get the results just alone with the dextrose prolotherapy and the ozone injections. Like I said, in more advanced cases, I'll do the platelet-rich plasma therapy, but most of the time, I have my patients start off on the dextrose prolotherapy because it's a lot cheaper and it gets the job done. Most of the time, I'll advance to the PRP later on from there. So the discomfort is pretty much the poke when you're getting the treatment. And then at the end, the ozone, I like to describe it as burny and stretchy. Or like in the shoulders, sometimes it can feel like you've gotten a little bit of a bump there, but it just rapidly fills that space. That goes away pretty quick, especially if you just keep moving around the arms. The biggest pain would be the day after the injections. So the day after is when you'll really start to see that inflammatory cascade coming on. As you see here, we're in the days area. So the next day, you're going to really start feeling that inflammation fuel the fire. And sometimes that inflammation can last up to about a week. It really depends on a case-by-case basis. I've had some people come back and say, oh, it didn't inflame me. Those are the lucky ones. Those are the ones that don't feel anything. Generally speaking, so if that gentleman you said with the knee pain, say he had an 8 out of 10 knee pain, typically speaking, we won't make it go above that 8 out of 10. Hopefully, we'll see it go to maybe a 4 to 6 in the next few days or the week. And then it'll just decrease with the amount of injections that we do. But I always counsel patients and let them know there could be a flare-up. It could be worse. For a few days, hang in there. It'll be okay. But realistically speaking, it just feels like a dull ache after you've received the injections for a few days.
Right. My experience is that the patients generally do feel better once they get past that initial mini flare-up. How long would one of these regenerative injections, how long would the benefit persist before they might need another one?
That really depends on each patient. So if you go out and re-injure yourself, obviously that's going to create a new injury and we may have to restart from that. But say we're dealing with somebody that is healthy, isn't really struggling from arthritis or anything, they may never need to come back for another injection, depending on if their body starts affecting that area again, or maybe it was never fully resolved. They may need a touch-up. I get patients in here all the time that some of them come in once a year for a touch-up therapy. That's after I've released them. So I'll put a lot of patients on a PRN basis, which means as needed, to where they kind of just listen to your body. I really encourage patients to understand and listen to their body to see when it's going to start telling you. So it's best if you've had the injections before and then you got to a good place where you felt really good, then if you ever start to feel pain twinges in the area or where it starts to come on again, that's where you'd want to come in. So really it's going to be in the patient's best interest to decide that on their own. However, once a year treatments are not a bad thing to keep things at bay and keep things moving in the right direction. But it's really a case-by-case basis. I get some people in here that even though they don't get to feeling that pain again, it just keeps it to where their joints feel great. So they'll come in once a month for a knee or a shoulder injection, just to keep things feeling good, because I don't ever want to go back to feeling the pain that they felt before they even started getting the injections.
Just a couple practical questions. How far ahead of someone coming in for injection therapy, how far ahead do they have to stop their anti-inflammatory? Or I guess maybe you want to speak, I assume they should stop some anti-inflammatories prior to the injection and for a certain period of time after.
Yeah, so I usually prefer that you stop everything that's anti-inflammatory for at least 1 week before and 2 weeks after the injections. Realistically speaking, if you're going through a treatment protocol with me, I don't like really any anti-inflammatories during the entire thing. However, I try to be a understandable guy and just let people kind of decide the best case of their own. But one confusion I do get a lot, and let me see, I think I have it pulled up here. So some of those anti-inflammatories actually, so these are drugs that should not be used. This is an after treatment care sheet that I give out. You'll see a lot of these on here. So acetylsalicylic acid, that's aspirin, ibuprofen, any other kind of meloxicam, Celebrex, corticosteroids. However, one thing that most people don't realize is that there are natural things that are very highly anti-inflammatory. Fish oils is a big one. It's becoming more popular where people are using fish oils all the time. That actually can interfere with that inflammatory cascade because fish oils are strongly anti-inflammatory. So is bromelain, curcumin, or turmeric, and then digestive enzymes can sometimes affect that, and then quercetin. So all these guys are natural things that are anti-inflammatory that will stop these healing cascades. And we don't want to interfere with that. That way we can get the best results from all of it. So also, when I'm putting people on a treatment protocol, most of the time I will prescribe patients to take a multivitamin as well as a collagen supplement, which is all outlaid in here, because the multivitamin basically provides a lot of trace minerals, vitamins, and essential things that help the body initiate that healing protocol. All of those aren't really listed on the inflammatory cascade, but they do affect that. The next biggest thing is a collagen supplement. So what we're trying to do is build cartilage, right? And cartilage is built from collagen fibers. Now, a collagen supplement is not going to directly go in and just go straight to building that cartilage. However, it gives enough amino acids to build extra and have extra floating around. When a person is on a collagen supplement, they'll notice that their hair may grow longer and quicker than it normally has, or you'll have to clip your fingernails a lot more often. But this is all just part of making sure that we're setting you up for the maximal healing. I actually prefer to see patients less than I would like to see them more. So it's not only my personal goal, but I know the patient's personal goal to get them in and get them out and feeling better as soon as possible. And that's one way that we can do that.
Are there any risks associated with these injections? Is there any contraindications to doing prolotherapy or the protozoan therapy?
So as with any kind of a invasive procedure, and this would be considered a minimally invasive, but still invasive, we're putting a needle into you and we're injecting foreign substances into the area. So with that, anything can be done, such as bruising, bleeding, tenderness in the area. There can be a risk of nerve rupturing, so to where you actually feel numbness or tingling in the area, or in extreme cases, there would be a loss of motor function. Knock on wood, I have never had any complications from that other than just people feeling a little achy after the injections. But there always is an option of that happening if we're doing a thoracic injection. So there's always a risk of a popped lung per se. So there can be lots and lots of contraindications to this. Those are the most typical ones that are seen, but they're very minimally, especially if you go to a skilled practitioner that knows what they're doing. As for contraindications, so a contraindication would be a complete tendon rupture or ligament rupture. That just cannot help with that kind of scenario. That would be a surgical intervention that would be needed to correct that, because if something's completely torn apart, there's no way that we can make it grow back together. So we need a maximum of about an 80% tear is where the prolotherapy is shown to be most able to heal that area. If there are any broken bones or anything in the area, we don't want to inject during that time, because we want that bone to stabilize before we start worrying about tendons or ligaments. Obviously, cancer in the direct area of the injecting can be a contraindication. So there are lots of different contraindications. We can go in. I could go on and on and on of what could be contraindicated, but those are the most common that people are going to see.
So, Dr. Moffitt, what kind of results do you normally see in terms of the success rate with this type of therapy?
Well, actually, as you can see here, I've got, I would say my personal success rate is around 90 to 95% on a lot of conditions. Now, granted, I do turn away a couple patients if I don't think I can help them. I have referred out for surgery in some cases. So I kind of pick and choose which ones are going to go. And if I don't think it's going to heal, there's no point in me wasting my time or the patient's money on any of this. Realistically, at the end of the day, I'm just here to help people get better as quickly as possible and get the results they want. But I would say the things that we treat most here in the office are going to be knee pain, back pain, and shoulder pain are the most predominant things that we treat.
I forgot to ask you earlier on, what was your you did extra training in this area after naturopathic school. Could you just say a little bit about that? Because I think people don't realize how much training you've had. Okay.
So I've done a lot of preceptor hours, which basically means shadowing doctors as you're going through medical school. I've done a lot of postceptor training, which is after I've graduated. So I went in and did mentorships with a lot of the docs that are doing these injections, and witnessed a lot of them and performed some of them while we were there. I've also read many, many books, and here's one of them back here. So just an injection techniques manual, to where it kind of goes through all the procedures that can be done. I've got 3 other books at home that I've read about those. I'm constantly looking at all the latest research showing the efficacy of these treatments, and always looking at ways to kind of switch it up and keep going. I would say there's never a week that goes by that I haven't done some more research on it. You'll also see me pull out my orthopedic exam books. So that naturopathic medicine, we learn a lot about orthopedics and manipulations. We learn about all the tests to go through that. So that set me up for identifying these. I don't necessarily require imaging for a lot of the injections that I do because I tend to find what's going on. Once you've palpated or felt a lot of things that are good joints and bad joints, you really learn how to decipher and see what's going on. And your bodies will actually tell me where the inflammation is. Normally I can feel inflammation around the area, bursitis, or we'll assess the tendon and ligament strength by putting them through a stretch test. And I've also done some certification programs. I'm always looking to actually do more. If you ask me, there's still so much more to learn about this field, and I've already learned quite a bit to kind of get me where I am.
Is it good enough for people who are looking at possible knee replacement or shoulder surgery? How often do you think you can help that? I realize it's a case-by-case situation, but is this a replacement for knee replacement?
Absolutely. So I get a lot of people in here that have been to orthopedic surgeons that have told them, absolutely, you 100% need joint replacements. And they'll come into the office, and lo and behold, after about 3 to 6 rounds of treatment of that dextrose prolotherapy, most of them end up walking out of here saying, I have no more pain. I feel stable. My knee doesn't feel weak anymore. My knee doesn't give out on me anymore. I'm able to walk up and down stairs without that pain. I don't feel clicking or popping in the area anymore. So Dr. Ross Hauser actually produced a lot of those studies that actually show that indeed the cartilage is being replenished and rebuilt in that area. So here is actually an image here showing how prolotherapy does regenerate the meniscus cartilage. As you can see here, this indeed was bone on bone in this picture here. But as you see after some rounds of prolotherapy, that it has now regenerated and reestablished that joint space. And I can witness that with a lot of my patients. I'll notice that the tibial plateau, so this area here in the femoral head here, or not head, but base, does elongate. So there's more space that builds up in between those with each round of injections. I have actually kind of formed a technique that I call a meniscal fenestration technique, that I actually go along the meniscus and irritate a lot of that border. And with that technique, usually it only requires about 1 round of treatment to actually get this to be more plump up to where the joint space that has been decreased is now more space forming.
So this I'm sure if the audience is listening, this is to me, it's an amazing therapy. Is it cost effective? Do you think what are the typical charges for like working on a knee or a shoulder? What would people expect?
Okay, so I will start with the worst knee possible. And the worst knee possible, let's go back to this image over here. So the worst knee possible would mean that there's some instability in these ACL and PCL ligaments, and LCL and MCL. So basically that just means that knee is able to rock in the places and ways that it should not be moving in. So the worst knee, there's an injury here, 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 and then the meniscus, so this joint space that we see here is actually decreased. So there's minimally anything there. And here we'll throw in the latest one. So the kneecap is kind of stuck and crunchy and not moving around. That is the worst case scenario. I would say that knee at the absolute worst case scenario, when everything has gone wrong, is going to take about 4 to 5 units of that dextrose prolotherapy. And the dextrose prolotherapy costs, currently we keep it very affordable. That would probably, for that first treatment, because it takes about an hour after doing all the orthopedic exams, I would say the person would be looking at anywhere from $300 to $500 for that first round. And then depending on how well they respond, they may only need 3 to 6 rounds total. It's per unit of the injectant and not per poke. So I often get patients asking me how many times I'm poking. If I'm counting, then I'm not paying attention where I'm going. So If a patient wants to know how many pokes there are, they can count them as I'm going through and treating all these areas here. As you can see, there are a lot of structures within that stabilize that knee. But realistically, it's actually pretty darn affordable. If you were to go to get a stem cell injection on this, and most stem cell therapy clinics are actually just doing that one poke wonder, where they just kind of inject it into this joint space and hope for the best. So I've actually had quite a few patients that have gone and gotten stem cells, and they're still coming and seeing me because they didn't get their problem resolved in the first place. And that stem cell injection into just one knee, I think it's running around $8,000 to $9,000 per knee just here in Kansas.
Yeah. Well, the thing that's really exciting to me about the prolotherapy is that you're actually working on restoring the dynamics of the knee function, or the dynamic of the joint. So you're not just working to heal the chronic inflammation, but you're actually restoring normal function. And that's a reason why the long-term prognosis for this type of therapy in a patient is going to be better. Because if you don't fix the dynamics, it's just going to continue to cause problems for that patient. So that's the beauty of the Prolo plus the Prolozone. And then when you throw in the platelet-rich plasma, you're stimulating the natural growth factors to further enhance more normal healing. So to me, you're healing on 3 different levels when you do this type of therapy.
And I would agree. And even to throw in surgical kind of cost for this one knee, surgeries can cost just for one knee is anywhere from $10,000 to $20,000 just for that knee replacement. Yeah, I've had several patients that have come in here after they've had a complete or a partial knee replacement. A complete replacement, obviously, they replace this part and this part of the knee, but a partial, they'll often only replace one side or one aspect of it. And I had a partial replacement patient come in where the medial collateral ligament actually was never healed, or I don't know if it was completely forgot about, or maybe it just tore after the fact. Who knows? There are so many different scenarios that can be thrown. But I was able to actually treat the knee that had the surgery on it and re-stabilize this ligament to where they weren't stumbling as much, because this was not even the knee they were complaining about. It was just something I found in my orthopedic exam flow, and was able to identify that there was laxity within this ligament. And this laxity in this ligament was allowing this knee to slop around, which then inevitably affects the gait or the way the patient walks. So it was making the other knee worse, because this knee that had already been repaired wasn't fully repaired, or like I said, a new injury occurred to where it kind of broke that into place. But sometimes there are chain reactions where if even the patient's not complaining of that area, we will have to treat another area to help with the other area.
Yeah. I think we want to open it up now, Dr. Moffitt, to some questions. If there's anyone that has questions. Yes, we got several questions, and Dr. Ann will come around with the microphone, and I'll repeat the question.
You'll repeat the question for our audience online. Have you used these therapies for like plantar fasciitis or suprapubic dysfunction? And then do you come to Wichita, or is there somebody here that we can see?
So the question is, do you use it for plantar fasciitis or suprapubic instability ligaments? And then the second part of the question is, do you ever come to Wichita as far as offering services here?
Okay, so I do use it to treat a lot of plantar fasciitis, and actually, so that plantar fasciitis, I pair that up with some physical therapy, whether I send you to a physical therapist or I just give you some at-home exercise to do, because so the calf muscle, I'm going to use my hand and my wrist. So we'll pretend this is the foot and this is the calf. That calf muscle actually, so most of the time we're walking, we're just going straight up and down with our foot, and that's it. So that's only going to exercise the back muscles and maybe a little bit of this front muscle. But there are all these other little muscles in there that actually stabilize and strengthen that foot to walk more predominantly. So if you can strengthen those side muscles on that leg, it's going to actually relieve some of the duty that these muscles in the back need to perform. And if these don't have to squeeze tight all the time to help propel that foot, then what that's going to do is that plantar fasciitis, all that is a big web on the bottom of that foot. So that web on the bottom of the foot, if it gets inflamed or irritated, or any of those adhesions or microscopic little scar tissue form, that's going to keep that from gliding properly, and it's going to get stuck along the way and just become quite a pain generator. And oftentimes the pain is worse when they're first getting out of bed. But there are also some ligaments in the metatarsal bones, so the bones of the ankle, that hold those bones into place. And often there's a deltoid ligament or a spring ligament that stabilize that arch. And if those ligaments have become stretched out to where that instability in those bones, so they're not holding into place, so I'll actually inject along those. I'll inject along the plantar fasciitis or plantar fascia and help lubricate the area, help to regenerate some more tissue, and also to stabilize those ligaments. And then we'll also give the physical therapy to correct the muscles in the leg. All of those together kind of bring in a perfect healing mechanism to drastically reduce those pains that are felt. Okay, so the other question was, do I ever come to Wichita to do treatment? Most of the time, most of my patients from Wichita actually drive up to Wichita to become treated, just because I don't make it down to Wichita very often. So I would say most of the time, no. If I get a strong enough need, we can always look at doing a day or two there a month. But for the most part, no, most of my patients do come up here to Hayes.
Here in Wichita, we do one aspect of that triad that we're talking about. Prolotherapy is using the dextrose to tighten up ligaments, and then the platelet-rich plasma is the regenerative growth factors. We don't do that here now. We do prolozone, which prolozone itself can be helpful with some pain relief and some regeneration of tissues. But we're if we get a significant need in the community, we are trying to set up some kind of a win-win process so that Dr. Moffitt can come and treat here in Wichita as well.
And Dr. Ron does those prolozone injections in Wichita, and a lot of patients get a lot of great relief from those. So, I mean, if you ever wanted to just kind of get started and you do live in that Wichita area, go see the Riordan Clinic in Wichita on Hillside, and they'll definitely get you started.
Another question. All right.
In the case of numerous degenerative discs, bulging discs, bone spurs, arthritis, where would you start in a treatment such as that, where there's numerous areas along the spine?
So when you have a spine that's got a lot of degeneration, how would you decide where to start?
A spine where it has a lot of degeneration.
Different levels. Yeah, many different levels.
Okay. So I would obviously start where the pain or the patient feels the most pain. If they are feeling the pain along that entire axis or that spine, then what I would do is then use my orthopedic exams and really try to provoke the areas to see where your body is telling me the most pain or instability is. So it's kind of a clinical judgment where we use patient values to kind of discern where it is. If they've got imaging, we'll use that as part of it. One thing I do want to say about that imaging is oftentimes degenerative joint disease is an incidental finding. That doesn't necessarily mean that is the cause of your pain. Just because there is decreased joint space or osteophytes or bone spurs, that doesn't necessarily mean that is the direct cause of your pain. Sometimes it's those ligaments and tendons that are actually causing that instead, which are really hard to see on x-rays. You just can't see them. And even MRIs are sometimes not picking up a lot of that. It just really depends on if your body has marked enough of an inflammation response to say, hey, I'm lit up here. I'm showing you where that irritation is. It's not always that way, but inevitably at the time. So if you feel pain all the way down your spine from your head to your low back, And you want the whole thing treated, yeah, we can do that. But inevitably, I try to spot treat so we can really try to figure out where the best area to start. But inevitably, it's just a clinical-based decision between the provider side and the patient side, and just kind of trying to meet in the middle and see what's the best place to start.
The other point that needs to be made with this is that going back to the basic Riordan Clinic philosophy is that the pain may be showing up in one specific area, but there could be even deeper root causes. You could have the so-called leaky gut syndrome. You could have infected teeth. You could have nutrient deficiencies. You could have autoimmune disorders, a number of things that are giving rise to the chronic degenerative inflammation. So certainly you want to treat the localized problem, but you don't want to forget to treat the whole person. And I think that's one of the really nice things about Riordan philosophy is to do the best with that holistic approach, but then with what Dr. Moffitt can do, he can really zone in on the specific areas as well.
And I'll piggyback on that. So if I get diabetic patients, some providers that actually do these injections won't treat diabetic patients. I do, and I see results. It just takes a little bit longer with those. So what we do is we work together to make sure that those blood sugars are being maintained and regulated, whether it's through medication, diet and lifestyle, or even supplementation. But if there's any underlying conditions, I often do have to work on that, which is why the first visit is always the longest. So an hour allows me to kind of go through some of the personal history, as well as doing those detailed orthopedic exams to really dial down on what the treatment should be.
Okay. Yes, sir. One more questions here.
Yeah, I've had multiple meniscus surgeries on both knees. They said they got arthritis running down the lower leg. Is that something that this regenerative stuff, will this help that situation, or does that arthritis in my lower leg start preventing any kind of regeneration that can take place?
So the question is, if you have pretty severe coexisting arthritis that's already caused a lot of degenerative disease and resulted in a number of surgeries, is that a reason not to embark upon this healing path?
It does definitely slow down the response a ton. So if you've got uncontrolled arthritis, it definitely throws a big curveball or wrench in the situation. But that doesn't mean that I haven't got those results. And oftentimes it can be a palliative treatment. It can really help decrease the pain signal from the area. I can get them to stabilize. It just takes a lot longer treatment. So the typical treatment would be 3 to 6 rounds. If I'm fighting against arthritis, it's really going to go beyond that. It's probably going to be more 6 to 12 rounds of treatment. It really just depends. But at the same time, if I get somebody coming into me for the injections that has severe rheumatic arthritis or something of that sort, I'm going to try to start working on those inflammatory cytokines on the inside with nutritional aspects, with dietary and lifestyle. It just really depends. But inevitably, at the end of the day, we have to control those chronic diseases that are affecting the joints that I'm trying to get treated, as well as the patient is trying to get pain relief in the area.
We're out of time, but I'm going to let one more question. Carol, go ahead. Yeah.
Almost the same subject. If a patient is a drinker and a smoker, will the therapy still work?
Yeah, so the question is, if the patient's got bad lifestyle habits, heavy drinking, smoking, and other factors, will the therapy still work? That kind of goes to looking at underlying causes as well, yeah.
I will not let anybody waste their money on platelet-rich plasma therapy if they're a smoker, especially heavy smokers. But smoking is probably one of the worst things you can do for your own body's internal stem cell production. So we produce all these growth factors. Cigarette smoking has shown to reduce the amount of growth factors as well as just blood flow in general. It's never a good sign if I go to inject somebody into an area where I'm causing pinpoint pokes with the needle. it's never a good sign if they don't bleed. I actually want to see a little bit of blood coming out of that. If they're not bleeding, I make sure that before they leave that office, they have a treatment protocol to help increase the amount of blood flow going throughout the body, because at the end of the day, the blood is the supply of the nutrients that brings it to the area. So smoking is definitely a no-go. What was the other part of the question?
Drinking, heavy alcohol use.
Okay, heavy alcohol use, I mean, it's not going to do you any good per se. If I see it as part of the obstacle to treat the patient, I am definitely going to work on that. If I see it as an obstacle to causing extra injuries in the past or in the future, we've got to work on that too. So, I mean, it's hard to say what I'm going to do with one particular patient or not, but I always take everything into consideration, and dietary styles, alcoholic consumption, smoking, all that pertains to your health.
Can you work on finger joints?
Finger joints? Oh yeah, I treat that quite a bit. I've actually had patients that come in with severe swelling of the joint and actually bone enlargement, so osteal enlargement, where their bone has just grown so much because there's so much inflammation. After several rounds of treatment, I've actually got those joints to shrink back down to what the normal size is. And all I'm doing is I'm treating, so we'll pretend this is a knuckle joint. So I'm treating these ligaments that actually surround that knuckle and stabilize it, because oftentimes especially if it's just one knuckle or whatever that's become a problem, often there was an injury that decreased the stability here. So just like I was showing with that slipping knee joint and slipping into areas it shouldn't be, so that slippage causes extra damage to that joint space and can really irritate it. So what we're trying to do is just restabilize that joint so that it doesn't become quite so inflamed, so your body stops attacking that one particular joint. Finger joints are pretty easy for me to do.
Okay, we're out of time. Let me just say one thing. I am so proud of Dr. Moffitt because he has taken the area of naturopathic medicine, which a lot of people assume is just like some herbs and potions, and what you've learned today is he's highly scientific, highly specialized, highly dedicated, and he's here in Kansas to give us good results for a problem that is getting ever more common. So please join me by congratulating him on his fine work.
Thank you. It was a pleasure speaking with all of you, and thank you for joining in.
And I'll add to that. If anybody didn't get their question answered either in person or online, those of you here in person, there is a card that says Dr. Call Time. Dr. Moffitt has his call time on Thursday evenings, correct?
Yep.
Thursday evenings at 5:30. So the number to call is on this card. You can call. It's a conference call, so you can ask any question you want, pertaining to what it is you're dealing with. And for those of you who are on